Anything? No, not anything. How about the fact
Well,
Furious voices on here all the time? I don't know.
that was an interesting update. I feel like we just had just an interesting, like, suddenly all these things happen on Zoom, and sometimes it works and sometimes it doesn't, and I don't know. It's just strange.
I agree.
I have to wonder how many of the people, doctors and team members joining us today are going to think that we are in the same office again.
Well, everyone, now that you said it,
I know.
my books are better. I mean, that's the bottom line.
I don't think that's true. I have far more books than you on this shelf, let alone at home. I mean, there's a lot of content there.
Chad, more isn't better. Better is better. Just saying.
Yeah. Well, welcome to our call. We're here a minute or two early so everyone can get situated. If you are here, go ahead and share with us where you're from and what your favorite summertime drink is. I'd love to hear what different things you guys have, wherever you are. So in the chat, go ahead and put those in. We can see those responses. And if you're here, yes, thanks, Abby. I was just going to say, go ahead and raise your hand to say hello. Remember, number one rule in any sleep training is that there is no sleeping allowed. So thanks, Melissa. See your hand. Really? No one likes to drink anything special during the summer? Lemonade, peach iced tea from Atlanta. Oh, no, that was Mike. Okay. Here from,
It's a true statement, though. I mean, it's different. I'm just saying, sweet tea and peach tea is different in the South and specifically from the peach state.
That makes sense.
Agree
James,
or disagree? Anybody else on the call? I mean, I don't want to be the only one here. Emily, you're from Athens. What do you think about peach tea and sweet tea?
And actually, we might be able to see good old water. Melissa from Atlanta. We're
saying water is synonymous with sweet tea, or are we just saying real water?
I think she's saying real water. Yeah. I'm a fan of soda water, angry water, my friends call it. But I just read an article which is really sad that apparently it has an impact on the teeth potentially. So I am might be a little heartbroken over these new developments. So
yeah, well, it happens. We seriously got 2 people to respond in the chat.
No, we got no, yeah, you're right. We got 2 people. We did get some hands. I see James' hand over there. That's okay. We've got some more opportunities here. There we go. More responses. I hear from Flowery Branch. Water's the best. Okay. Lindsay, Middle Georgia, ice cold beer is my favorite summertime drink when not at work, of course. I would hope not. That's a good policy. I did meet someone when I worked in a dental practice who did some interesting drink choices in the middle of the day. It's not okay. I don't think she made it too long at our practice at that time. So we do have some awesome hands. Awesome. Satsuma Mule. I've not heard of the Satsuma Mule. Love my Irish Mule. That's a good one.
I got you, man.
Yeah, I gotta try that one. Well, we're a few minutes after. I think we can definitely get started. And yeah, Mike, you want to open us up?
No, I'd rather keep talking about peach tea. I'm just kidding. Yeah, let's do this, guys. So by the way, we will probably stick our proverbial West Coast foot in our mouths tonight by saying you guys. Ladies, please don't be offended. This is our Southern California version of y'all. That being said, welcome. We are stoked to have y'all and you guys here tonight. We're talking about screening for OSA. We're talking about how COVID has impacted that. What are specific dynamics that you all can work through in the practice to get more OSA patients? Actually change that. You already have the OSA patients sitting in your practice in the chairs. The question is, how do you have the conversation and not break everything about your schedule and your dental workflow? This guy is going to bring it tonight. Let me introduce Chad Wooters. Chad is our executive sleep coach here at Awaken to Sleep. He has been in the dental industry and business for many years. Chad, I always forget your number, and I apologize for that.
Okay.
But between coaching and sleep and dental, this guy really takes the screening protocol to the next level. If you've tried to screen for sleep apnea in your practice, or you've had difficulty even launching that with your team, please pay attention. And by the way, just because this is Zoom, he's 3 personalities in his screening protocol. I'm not going to steal your thunder, Chad, but Chad, the hygienist, talks very different than Chad, the dentist. Listen, guys, we're going to have fun tonight. The reality is we want to show you how to screen better. We've got a short time to do it. Chad's going to bring the house and showing you that clinical workflow. So bring your 110%. We recognize you're a couple hours ahead. We're going to have some fun, hang out for the next hour, and you get a CE for that. So let me get into that. All the standard stuff you hear every time you get on a webinar. It's an AD PACE CE event, which means you get 1 CE if you hang out for an hour. That means occasionally you do have to raise your hand, interact in the chat, show us that you're alive and well since we can't see your shining face. That being said, at the end of the webinar, you will get a link in the chat that you can click. It takes you straight to a questionnaire that will take you a maximum of 27 seconds if you read every word out loud twice. It's super short. Click the link, answer the questions, you get the CE. Auto generates your certificate in your email. Speaking of email, if you miss the link in the chat, you'll get an email tonight 1 hour after we finish. So if that's 5:15, 5 o'clock Pacific time, 8 o'clock Eastern, 1 hour after that, it will be in your inbox. If it's not there, it's in your spam. If you still can't find it, please message us. We have an instant support feature on the website. You can ask us that. We will respond to you as soon as we get in tomorrow morning. All right, tonight, screening, COVID considerations, Mr. Chad Wooters.
Awesome.
Take it away, man.
I also know I've talked to a couple of doctors about this webinar, and I just want to ask a quick question. If you are a team member on this call, could you raise your hand for me? I want to see. No, I don't have your camera, so this raise your hand function. There we go. I got at least 1 team member here. Okay, there we go. That's what I'm talking about. 6 team members, awesome. If we have our team on this call, this is going to be incredibly beneficial for them. We're over 10 people right now who are here as part of the team. That's awesome. Doctors, if you're here alone, don't worry. This is recorded, so we're going to make sure to you can share this with your team, and there's some other opportunities as well for you to get this to them. Thank you, team, for raising your hands. I'll ask about the doctors a little while later here. Let's talk about the first thing as it relates to screening. Oh, Chad. Mike. Yeah,
I messed up already, man. Folks, chat, not Chad. Chat is where you hit your tech support questions or the responses. Some of you all have put your drinks in there and where you're from. Thank you. Use the chat feature for any tech support or responses to the speaker. If you've got questions, please put them in the Q&A. We will stay here until all your questions are answered tonight. So as you think about them, throw them in there. We'll be asking every single one of them tonight. All right, Chad. Sorry, back to you, man.
No problem. So let's talk about the first thing on the table. What about dentists and screening for sleep apnea? In 2017, the American Dental Association came out and said that dentists need to be involved in screening patients for sleep-related breathing disorders. The reality is that you, as a dental provider, whether you're a team member or you're a dentist, maybe even a front office person, you have a unique opportunity in that you see patients more frequently than any other healthcare provider, and you actually have a lot of things that you see every day that relate to the airway. And we're going to talk about that a little bit later, but know that your governing board on a national basis has actually said that you should be involved in identifying those patients who are considered at risk. So that's the first thing we want to take off the table. We know that you should be involved. The second question is, how has COVID impacted dental sleep medicine? Well, the first thing that happened when COVID hit was that we saw that oral appliance therapy was being recommended as a primary recommendation in light of the fact that CPAPs generate aerosols. So to reduce the spread of COVID, to really help patients still get good sleep that takes care of their immune system and not go without treatment in households where there's multiple people living there or immunocompromised individuals, they're saying that oral appliance therapy could be used as a contingent therapy to make sure that patients were treated. So that was the first thing. A little while later, we had this amazing new guideline come out from the American Academy of Dental Sleep Medicine that said that dentists should be administering and ordering home sleep studies. Now, this is a really crazy opinion because for a while we had to look at the state dental boards and see what was just their consideration. And we have to consider that. We've got some updates on that a little while later as well. But what does the dental sleep medicine industry say? What does the medical industry say about sleep testing in the dental practice? Well, the largest academy for dental sleep medicine, really well, I guess they're not the only one. They came out and nationally stated in August 28th of 2020 that you as a dentist should own and operate equipment, and that you should be able to hand those out to patients or order them for patients who are considered at risk for an airway concern. So this is a really important guideline. I encourage you, obviously this is a screenshot of the guideline. So, or position, go and check out the position, look up American Academy of Dental Sleep Medicine, home sleep testing position. Just to read through the entire thing if you want to understand it fully.
Man, you are like 6 minutes in and you already started getting questions. All right, I'm going to try not to keep you off track, but on this slide, we got a doc that asks, if I own a home sleep test, because you're saying that they can, if I own a home sleep test, can I diagnose it or does the MD have to? We know the answer to that question. Please answer it in detail. And then if an MD has to interpret the test, how do they do that? Like,
Got it.
Is it just their local doctor? Like, how, if you can take.
Yeah, so real quick, and I made sure to capture this in the screenshot. If you look at the bottom left-hand corner, it says data from HSATs, that means home sleep apnea tests, should be interpreted by a licensed medical provider for initial diagnosis and verification of treatment efficacy. So what that means is that if you have a patient who's not diagnosed yet and you give them a home sleep study, that needs to be read by a board certified sleep MD in order for that to be considered a valid study and for you to not be considered practicing outside of your license. So if you have home sleep studies or you're looking into getting home sleep studies, then you need to either find a local physician, which you can do. It's a little challenging. They typically like the CPAP model, or you can use a service. Waken to Sleep has one on our website where you can upload that data. We have physicians in all 52 states, and we'll have that read, interpreted, and a recommendation for treatment provided based on the level of severity. So you can own and operate them, but interpreting the data for diagnostic purposes is not something you can do. So make sure you find an interpreting provider and also that efficacy. Now that leaves some room in the middle there because we have titration studies that we can do, which help us find the most effective physician as well. That's a whole nother topic. We're not going to jump into that, but know that you can own and operate home sleep studies in most states. And the states that you can't are New York and New Jersey. So we'll talk about Georgia here in a little while as well, because there's some considerations there as well. So let's jump into the actual topic of screening. We now know that we should be screening. We now know that we can operate the tools necessary to get a diagnosis, but what is the process to get to that point? I actually really like talking about this story because, as Mike mentioned, I used to work in a dental practice. And while I was in this dental practice, we started talking about sleep medicine, dental sleep medicine. And the practice owner and I were talking one day, evaluating, what this looks like to implement. And he said to me, why would you do a test? Because I was looking at trying out one of these devices for myself to just see, maybe, I don't know, let's see what it feels like. And maybe I have a problem. We'll see. He said, why would you do that? Look at you. You don't have a problem. And I was like, oh yeah, I guess that makes sense. At the time I was $130, 5'10", relatively fit. Like I don't think I have a problem. I snore a little bit, but no big deal, right? People snore. Well, come to find out, after I came to work for Awaken to Sleep sometime later, we have to try out every home sleep study that we sell or support. And the reality was that I actually had moderate sleep apnea. I used to stop breathing or almost stop breathing 23 times an hour in my sleep. And that was back when I was 30 pounds lighter. And so what I saw was that because I was the wrong stereotype, I was not screened appropriately. And if I continued to work in that practice and not get involved here, I would not have been diagnosed. And statistically, I would have lost 7 to 10 years of my life. So when it comes to screening, I get a little bit amped because if I was your patient in your chair, I would hope you would talk to me. And we're going to teach you today, show you today how to find signs and symptoms for someone like me who doesn't fit the stereotype that is in your practice and has a serious problem. So on the screen, you've got my little family photo on the left-hand side with my little 6-month-old puppy, and my wife and I just celebrated our first anniversary 3 days ago, something in there. And on the right hand side is some more pictures of my family. So those are my little brothers, not my children. But just the fact that I get to be here, I get energy to engage with them because I did receive treatment for my sleep apnea, is amazing. And so I love this story. And to tell you the truth, my in-laws have all been tested, and some of them in treatment. My family's been tested with treatment. This impacts more than just a single person who gets treated. It impacts, the impact is compounding. And so that's what we're going to talk about today, is how exactly to do that. Here, when it comes to the whole process, we need to understand the screening aspect as it relates to the treatment aspect. In any clinical process, we have a couple things. One, we have the step of identifying patients who are considered at risk for an airway concern. Now, I want to draw your attention to that verbiage real quick. The rest of today, until we get kind of near the end, we're going to use the verbiage airway. That's your first takeaway from today. We don't talk about sleep apnea until we have a diagnosis, okay? As a dental team member, you work in the beginning of the airway, you work in the mouth, and that's going to be our primary point of concern. So we're going to identify patients who are at risk. The sole purpose of identifying these patients is to get them to the assessment part, which is to assess the presence and severity of a condition in a patient. And so we screen them for an airway concern and we test them. They'll come back with a diagnosis. We'll talk about how that works. And depending on their level of severity, if you joined us last time, if not, there's a webinar or recording of that as well. Dr. Manning shared that depending on their level of severity, we can actually treat them with an appliance as their first line mode of therapy, if they're willing and if they are a candidate based on your consideration of their dentition. So let's jump into the nitty gritty. How do we identify these patients and what does this look like? One thing, disclaimer before we jump into the actual how-to, is that what we're talking about here is part of a workflow. In your dental practice, you have a successful set of systems, there's a lot of S's in there, that work well. You probably are succeeding in dental and you make some good money and you're helping a lot of people. What we talk about in sleep is supposed to fit into that existing system. We're not going to teach you a set of protocols here that we say, hey, stop doing what works and start doing this. So take what we have to say with a grain of salt. And if you want to learn or you want to talk to a coach about what this looks like in your practice, I would encourage you to consider coming to one of our courses. We have a lot more time. We have a lot more face-to-face. You're on camera, we're on camera. You can come off mute. We can interact and ask the hard questions about your specific workflow. So just know, take what we have to say, understand that it's a suggestion and that we want to fit it into your existing system. And like I said, if you want to learn more about how that fits into your practice and work with a coach one-on-one, consider coming to one of our courses. Let's jump in. First thing first, we're going to screen on a team level. That means that our front office, our dental assistants, our hygienists, and our doctors all play a role in this. It starts with the front office. What we see here is in this study done by ResMed is that patients who had X comorbidity, so the comorbidities are on the left-hand side, also had sleep apnea at this percentage. So I'll read through them and that'll make a little bit more sense. And we'll draw your attention to 4 big ones. Now, on the objectives of the webinar, you may have noticed that we're going to help you find 10 patients who need a home sleep test. You might find those 10 with this one slide. I encourage you to stay till the end though, because we've still got some good stuff to show you, okay? The big 4 we want to look at for your existing medical history is, the first is hypertension. 37% of patients who had high blood pressure also had obstructive sleep apnea. The second big one is type 2 diabetes. 72% of patients with type 2 diabetes also had obstructive sleep apnea. 77% who had obesity also had sleep apnea. And 83% of patients who took 2 or more medications to manage their high blood pressure, they also had sleep apnea. So whenever it comes to your front office and that medical history, consider marking the corner of your route sheet, either digitally or on paper, with an AI for airway, to note that that person has a risk factor as relates to sleep apnea, to airway. If they have 2 or more medications that are high blood pressure, there's an 8 in 10 chance that that patient also has obstructive sleep apnea. So we need to talk to them about that. Real quick, I just want to see a show of hands. How many of you found 10 patients just based on this one slide who need to be talked to about doing a home sleep test? Yeah, there we go. All right, we got 5 or 10 people so far. Good. I'm glad to see you're paying attention. You guys are doing the first rule of a sleep program very, very well. Oh, we got almost 20 people who found patients right on that first slide. Awesome. Hygiene. Now, if you're a hygienist on this call, don't shoot me. I promise you what we're going to show you workflow wise later is not going to break your existing time frame and how you have with patients. This is just to say that hygiene, you have an opportunity because you have a relationship. And what we're going to talk about later is how to identify patients who are at risk for an airway concern by just noting things that we see every single day and by adding 1 or 2 minutes of conversation to the beginning of our appointment and the end of our appointment. If you want to use a form, then there's literally like 50 forms out there you can use for sleep apnea screening. Pick the one that works best for your team. We've got a couple that we recommend. We got the Patty, we've got the Epworth, we have the Awaken to Sleep Screener. We have all of these things that are really great. Pick which one works for your team. The second thing is that we need to do patient-centric screening. If the word that you're about to talk to the patient with has more than 3 syllables, the patient probably doesn't understand what you're talking about. So we need to use words that are simple. We need to use words that communicate what we're trying to say to the patient. And we need to use words that they understand. So we'll talk about this a lot later, but people don't care what you know until they know that you care. So what are the things that we're looking for? Besides medical history, besides using our forms, what is it that you see every day in the dental practice that can actually be used to identify these patients who are at risk? The first thing is our intraoral crowding. So we can see here 2 sets of lines. The yellow lines are normal, the white lines are enlarged. And what we're looking at here is if you imagine the mouth as a box, the box has a certain amount of space available in it that air can pass through to enter the throat and therefore the lungs. If we add more stuff in that box, less air can pass through, increasing the likelihood that we're going to have a collapse. So we'll talk about the collapse a little bit later, but what I want to draw your attention to is the uvula specifically. We see here that uvula is elongated. If you see a patient who has an elongated uvula, just know that that's not natural. No one is born with an elongated uvula. That is a result of a negative pressure system, pulling on that tissue, stretching it out. So one of the surgeries to reduce it is to cut it off. So intraoral crowding initially is just a great way to look at that. How big is the box? And does everything that's currently there fit in the box? Or is it blocking their airway? Another evaluation that's very, very common is the Patty. Dr. Patty designed this. This is an evaluation to determine the space between the base of the tongue and the soft and hard palate. What we want to do with this particular evaluation is we want to make sure that the patient is sitting upright at a 45-degree angle, and we want to have them stick their tongue all the way out, just like this. April, thanks for that comment. She says, I have seen a patient with the uvula was long enough that the end disappeared behind the tongue. I'm sure a couple of y'all have definitely seen that before. Sorry, going back to Patty, I got distracted. I love when you guys engage, so please give us your comments. Patty, stick your tongue out. Make sure the patient does not say ah. And we're going to look at the following criteria. If you can see clearly see the uvula, the back of the throat, the pillars on the sides of the tonsils or where the tonsils are, we're going to give that patient a class 1. They're not considered at risk for an airway concern. Class 2, we see the uvula starts to drop below the base of the tongue, but everything else is very clearly visible. That's class 2. They're also not at risk. Class 3 and 4 are considered at risk. And what we're starting to see with class 3 is that we can only see the top of the uvula, or if they don't have one, where it would be, and very limited space between the tongue and the soft palate. And in class 4 patient, we may only be looking at the hard palate. It just depends. Sometimes you can only barely see the soft palate, and we're just looking at the hard palate, and they're obviously at risk as well. So this is actually commonly used. If you do anesthesiology in your practice, this is something that you probably perform regularly. This is used to determine the patient's risk for an airway collapse when they're being put under for surgery. So if you ever had an ENT surgery done or something complex with the patient, this is probably something you've done. They're very, very comfortable for the patient to do. Have them sit up, stick their tongue out, not say ah. If you have questions about that, please put them in there as well. We are happy to jump in and explain that again a little while later. All right, we're going to get into what I call the meat and potatoes. So this is our really the comprehensive review of what you see every day and how it relates to sleep apnea. So we'll go through these kind of 10,000 foot view just to kind of show you what to look for. And if you have questions, ask those, and feel free to reach out to us after as well. So the first one is enlarged tongue. We talked about the box of the mouth. If the tongue doesn't fit in the mouth, then it makes sense that it'll fall back and cause that collapse that we're talking about, that causes an apneic event. One of my favorites is actually acid reflux. So you can see yellowing on the tongue in this photo here. And so we need to determine if this is acid reflux or if this patient was someone who very considerately decided to go by the donut shop and pick up a cream-filled donut before their hygiene visit. So how do we determine if the patient was just thinking about you before they came in or if it's acid reflux? Very, very simple. I recommend warning the patient unless you don't like them. It's completely your prerogative, but take a utensil, a probe, one of those things, and let the patient know you're going to lightly scrape the top of their tongue. Scrape the top of the tongue, and if the yellow residue comes off, it is not acid reflux. If the yellow residue comes off, you know that that patient was just thinking about you. So if it is stained, then that is acid reflux. So what we see happens and how this relates to the airway, I'm going to turn sideways so you can kind of see. We have a collapse that occurs here in the posterior hyperpharynx. That causes an airway pressure system here in the throat, which puts pressure on something right here called the esophageal sphincter. This valve stops stomach acid from crawling up the airway. Over time, as this negative pressure system in the throat builds, it puts pressure on this valve, weakening it, allowing it to loosen and allows acid to crawl up the airway, therefore staining the tongue. So remember, if you scrape it and it does not come off, that patient objectively has acid reflux. This is also where I want to pay tribute to all of our dental team members here. Before I worked in dental, I was the worst patient imaginable. I was that guy that said, oh, you have bruxism. And I was like, I don't think so. And then the doctor was like, well, you know, I have a doctorate in dental. And I was like, oh, I still don't think I have grinding of my teeth. And he was like, well, you're wrong. I was wrong. So I apologize on behalf of patients everywhere like me, like I used to be. We have no idea, okay? We're not as smart as we think we are. And so thank you very much. You guys have to put up with more excuses than any other industry in healthcare. And I applaud you for that. I bet it's challenging. So we recognize that here. And this is one of those ways to say, yeah, I'm sorry, your opinion on the matter doesn't actually matter because you do have acid reflux. Now, I would recommend not saying it like that. We'll talk about how to say that in a little while here. But it's good to know that we have an objective way to evaluate these ideas. All right, speaking of bruxism, we saw a study done in Portugal that showed that 70% of people who grind their teeth also have obstructive sleep apnea. A further evaluation of these patients showed that when treated with a bruxism guard or a night guard, 50% of them had worsened apnea. So 70% had apnea, and of that 70%, 50% had worsened apnea when they were treated with a night guard. So we actually formally recommend that if you have a patient who comes in and does have bruxism, we need to evaluate the fact that if the bruxism is secondary or primary. So make sure that you get a home sleep test or in-lab test, whatever your preference is, to get the patient tested to make sure that we're treating the right thing. Most appliances nowadays can handle a bruxer, or you can build one with special customizations that will allow you to take care of those issues. But treating your sleep apnea may actually treat your bruxism. It depends. So let's make sure we get a home sleep test to determine if that's a factor. Another issue is scalp tongue. That same mechanism that causes the bruxism, that forward upward motion of the jaw and that usually consistent pattern causes scalp tongue. The brain yells forward march and our body tries to get the airway open. If your tongue is thrust into the back of your teeth 20, 30 times an hour every night, then you'd see some long-lasting impressions there. We see attrition, so additional wear and tear for those patients that actually do take care of their teeth, but yet we see that their teeth are they're just not lasting like they should for someone who takes care of their teeth. That could be a result of sleep apnea or an airway concern, and high vaulted hard palate. We talk about that idea of the boxy airway or the airway, the box of the mouth and how it relates to the airway. This determines the capacity of the box, how much space is available for air to pass through. And remember, if the tongue can't go up, it's going to go back. Last and definitely not least, probably my favorite, like number one, second to acid reflux, tonsils. And the reason is that I mentioned earlier, I got diagnosed with moderate obstructive sleep apnea by a NOx T3 unit of all units. And this was my issue. So I finally got my tonsils cut out and cured my apnea. Don't have it at all anymore. I have an AHI of 1. So that's pretty awesome for me. And it was awesome. Now, as a side note, surgery was the best option for me because my tonsils were the size of golf balls. That being said, I was treated with an appliance for 9 months pre-surgery. And those were some of the best months of my entire life. To go from being sick every 6 weeks to not being sick for 9 months and actually not being sick for almost 2 years was completely life-changing. I can't even, words do not begin to describe the change in my life that occurred there. So some really great intraoral signs here. And as you can see, we start to get this picture. And we have a couple more slides I want to go through. And I want to ask you a favor. For everyone who's listening and on today, I want you to pick your 3 most interesting intraoral signs or medical history concerns. What are your 3 favorite things or most things that you find the most interesting that we've discussed so far? List those 3 in the chat. And I want to be specific. Don't tell me medical history. Tell me hypertension. Don't tell me intraoral signs. Tell me bruxism or tongue scalloping or high vaulted hard palate. Give me 3 of those in the chat. We're going to use that a little while later as it relates to demonstrating our workflow. Okay, give me 3. Now, if you weren't here last time, don't worry. We covered some of these topics, and these are the other pieces of the screening conversation. We've got our medical history, we've got our intraoral signs, and we've got our subjective symptoms, or what I like to call them, mostly great conversation starters. And if you're incredibly brave, they're all great conversation starters. I'll let you figure out what that means on your own. But if they do report memory loss or morning headaches or chronic fatigue, those are great ways to start conversations. So having something like this in your practice is a great way to start that conversation and really engage with what matters to people. Remember, people don't care what you know until they know that you care. Thank you. I got some awesome signs in there. Bruxism, uvula, hard palate, donut icing. Yes, thank you, Melissa. We've got some great things in there. Thank you for picking out your favorite. And we're going to use a couple of these in just a second here. One of the forms, and I'm going to be very candid with you. I personally think the best screening protocol does not use any forms. That's a personal thing as a coach. Patients get less frustrated with offices that don't use forms to screen because they don't feel like it's as repetitive. When you identify things and verbally communicate with patients, and you can do this as a team, and we'll talk about how in just a moment, they feel related to. Forms just feel legal-y, you know? They feel like, oh, why do we gotta do this form here? But I will say the opposite side of that is that forms hold teams accountable. If you tell your team to use a protocol we're going to discuss in a moment here, and you don't give them a form, there's a 50-50 chance that they won't actually do it. So, and let's go to a course we get coaching, in which case, you know, the numbers change a little bit here. I would say if you need a form, use a form. If your team can be calibrated and start this without a form, consider that. And I'll show you exactly how to do this without forms in just a moment. That being said, this is a great evaluation here. This evaluation gets rid of patient excuses entirely. So take a look at that first question. Have you ever been told you stop breathing while asleep? If yes, answer 8 points. It does not allow room for the, if yes, please explain why. It says, we don't care about your excuses in this questionnaire, and hopefully you don't say that to a patient, but sorry, your excuses aren't relevant. Yes or no, if yes, 8 points. Tally up your points at the bottom, and you look at your score for risk factor of an airway concern. So I love this questionnaire. Take a picture of this. Definitely would recommend using this in your practice as much as possible. Hi, Mike.
You found another one. So first off, question is this part of a bigger form? Is this the whole form that they're taking a picture of? And then the second part to this question that was asked is, can they get said form from us? And I think you have an answer to that.
I do, and I did forget, so thank you. We have a custom form we call the Awaken to Sleep Screener. It's incredibly comprehensive, and we're going to be sending one to every single person on the webinar tonight. So that'll be in your email that Mike mentioned at the end of the night. Check that out. There's going to be a button that says download the form. That's the button you want to click. You're going to get this form. It actually has a Malin Patty built into it and a couple other intraoral considerations as checkboxes. It's a really comprehensive form. Take it, tear it apart, use it as you will. It's good. All right. Any other questions, Mike, or was that it for right now?
No, that was it for now.
Okay. Let's jump into the purpose of screening. And I mentioned this earlier. We've got our intraoral signs. We've got our home sleep study, our intraoral signs, medical history, subjective concerns. But the purpose of all of this is to get them to a test. So when we're looking at testing, there's quite a few different options as it relates to it. And again, last month, we talked about this with Dr. Manning. We can get that patient to do a home sleep test or an in-lab test. There are only two options as relates to testing. We know that the American Academy of Dental Sleep Medicine has said that you should own and operate equipment if you can, which you can in all but 2 states, I believe. So what does it look like here to test our patients? How do we get this done? That's going to be the next part of this. But just know the whole purpose of identifying these patients who are at risk is to get them to do a test of some kind. Once they're tested, then we can come back and get them treatment planned for an appliance if clinically appropriate. And we'll talk about that timeline. I'm going to teach the workflow first, but after that workflow, we'll be able to recap, or after the screening workflow, we'll recap the treatment workflow briefly.
I'm trying, man, but you're breaking things here. All right. So we know we have a bunch of folks from Georgia on the webinar tonight. Somebody asked, hey, I've heard that I can't own home sleep test units in my state. How does this work for me? And if I have a unit, how do I work with a doctor? So
got it.
Basically the major concern of Georgia is they've heard that they can't own units. Can you speak to that?
Yeah,
and I'm sorry
absolutely.
if I'm out of order here, but
no, you're perfect timing. I know we have a lot of Georgia docs here, so check out this slide. Like I said earlier, New York and New Jersey, those states specifically, you're not really able to have a home sleep test. So the only ones I know of that go out there. And if you know of any other states, let me know. Georgia's guidelines state that dentists cannot order a home sleep test for the purposes of diagnosing a patient. So that's the guideline there. That means that when it comes to testing patients in Georgia, you can and you should operate your own equipment so that you can do titration testing. That's going to be an important part of your workflow, but you can't order that diagnostic home sleep study. What does that look like then? At that point, when you screen a patient, and we'll kind of mention this again in a few minutes here, when you screen a patient, you're going to actually have to get them to talk to a doctor first. You're going to have to get a medical doctor involved, and you can do that via telemedicine. Telemedicine is one of the beauties that came out of COVID. We can screen the patient in the chair, and as they're checking out, get them scheduled to talk to a telemedicine doctor. If you own and operate your own equipment, then after that visit, when the doctor prescribes a home sleep test, they can come back to your dental office and pick up that home sleep test. They can do a one night of study, bring it back, and get it interpreted by that same doctor who performed the initial consult. That's incredibly powerful. They get to see the doctor face to face, and then they get the diagnosis with a recommendation for treatment. It's a small step in the workflow, but it's all you have to do for that diagnostic home sleep study. That for Georgia docs, that's all that's required. So it's a small step, and it can be built into your workflow, and it doesn't cost a whole lot there. And if anything, it actually builds a little bit more value in your treatment plan. So if you're a Georgia doc, you want to talk about that with us, make sure to go to our website and schedule a call with us after the fact. We have to do that. We also have a telemedicine service that we provide that works great for any model. So with that, we do have time for questions later. So don't worry if you have questions that haven't been answered yet. We have time for that. Alicia asked, so in most states, the ordering physician would be pulmonologist or allergist, ENT, correct? Those could be just a general doctor, GP doctor. It could be a sleep doctor. It just depends. Our service usually uses sleep doctors. So we can definitely get started with those. Those other doctors as well could also refer out in the Georgia states. So let's jump into one quick video, give you a break from hearing me, and we're going to go through our screening protocol specifically. So, all right, let's watch the video.
It's just, there's all this pressure, you know? And sometimes it feels like it's right up on me, and I can just feel it, like literally feel it in my head, and it's relentless. And I don't know if it's going to stop. I mean, that's the thing that scares me the most, is that I don't know if it's ever going to stop.
Yeah. Well, you do have a nail in your head.
It is not about the nail.
Are you sure? Because, I mean, I'll bet if we got that out of there...
Stop trying to fix it.
No, I'm not trying to fix it. I'm just pointing out that maybe the nail is causing...
You always do this. You always try to fix things when what I really need is for you to just listen.
Yeah, see, I don't think that is what you need. I think what you need is to get the nail
See, you're
out.
not even listening now.
Okay, fine. I will listen. Fine.
It's just, sometimes it's like, there's this achy, I don't know what it is. And I'm not sleeping very well at all. And all my sweaters are snagged. I mean, all of them.
Yeah, that sounds really hard.
It is. Thank you. Ow!
Oh, come on. If you would just...
Don't.
Try to see things my way. Do I have to keep on?
So it's not about the nail. People don't care about what you know until they know that you care. So how do we communicate this idea with our patients? We're going to use some of the things that you said in the chat earlier, and we're going to use these examples in what we call our 3 favorite things protocol, or as Mike referenced it, as Chad's 3 personalities. And I have one, I promise, but we're going to have to, because this is a one-sided Zoom, I'm going to have to show you a little bit of acting here as relates to our screening protocol. So before I get started with this protocol, I do want to kind of give you a disclaimer. In college, I took one acting class. It was one of those courses, I just needed a GE, 1 more unit to be considered full-time this semester. And it was like one of those Saturday, you show up for 3 Saturdays for 4 hours each Saturday and you get 1 unit. And it was a pass or fail. That acting class, you know, you show up. I remember this course because it was excruciatingly painful. And I failed. So I failed a pass or fail class by not attending this incredibly memorable event. Long story short, I ended up getting my grade fixed because I was there. I also made the joke to the teacher that I was so good at acting, I was a chair. He said I was just not memorable enough. So that's I'm going to do some acting for you on this side of the screen. Give me some grace on that end. And to that end, just know that what I'm going to demonstrate here is a set of intentional tools to communicate. So if you're a team member who has questions about what we're going to go through today, just know that this is designed to communicate care. That's all we're doing. Okay. And I'm probably forgetting 1 or 2 things, and we'll come back to those as they come up. So as you've noticed this far in the presentation, we've got our medical history, our intraoral signs, we've got patient complaints. I also saw a doctor I've been talking to this week as well, Dr. D. One great sign is the patient having a hard time being reclined in the dental chair. That is wonderful. I mean, it's not wonderful. It's a problem. That's a great pain point to hit on though, because they're already concerned about their airway and choking. That's pretty good. Also, if you have patients who fall asleep in the dental chair, they need a home. Do not let them leave your practice without finishing something like this protocol, okay? Chair reclined and patients falling asleep in your dental chair. Those are 2 really big ones. But you're probably sitting here like, oh my gosh, Sally who comes in, she's got 8 of these things. She's got the bruxism, the tongue scalloping, and hypertension, and morning headaches, and daytime fatigue, and oh my, there's so many things wrong with her. So you leave today, you go in tomorrow, you talk to Sally, and you're like, Sally, this is the list of things that are wrong with you. Well, hopefully Sally comes back for her next cleaning appointment, because anyone who gets a laundry list of the things that are wrong with you, they're not usually too thrilled, okay? So we need to find a way to communicate things that are wrong with our patients that we find interesting, that are concerning as relates to airway. And that's what we're going to discuss here. So one quick structural thing for this section of content. When I'm on this side of the screen, I'm Chad, the hygienist. When I'm on this side of the screen, I am Dr. Smith. And when I'm right here, I'm probably just talking to you, okay? Lastly, if I do this, that means I'm either starting or stopping my scene. So you know that I go from teaching to acting. So let me give you a little background on this demonstration. This is going to be a normal hygiene visit, and it assumes the standard workflow that what happens at the end of the hygiene visit is that the dentist comes into the operatory and performs a quick dental exam where treatment is discussed and dental concerns. That's the typical workflow. Give me a hand up if that's how your practice works so I can see who I'm talking to. And we're going to demonstrate how to very easily, very quickly, just discuss this without breaking anything, okay? So as a disclaimer, we're not going to break your existing workflow, I promise, okay? So give me a few seconds to show you exactly how, okay? So our patient today is Mrs. Jones. Mrs. Jones is not old, but not young. She's got grandkids, but she's still working a little bit, and she's just enjoying her life. Doesn't have to work too hard, and just having a good time. Mrs. Jones is also the sweetest patient in the world. She's the patient that if you're a hygienist, you make sure that if no matter what, if you're sick, and at least with something that won't be spread easily, whatever it is, you're going to show up to work that day because Mrs. Jones is there. Because you know that if you don't service Mrs. Jones that day, you'll never get her back because everyone wants her as her patient. That's our patient today, okay? So I don't know if you have a patient like that in your practice you can think of, but sweet Mrs. Jones is our patient today. And she comes in, and we just learned about screening for sleep apnea or airway in our practice. And so we're gonna start this conversation. Now, when it comes to this conversation, Mrs. Jones is updating her medical history forms. And in this update, she shows us that she has hypertension. So with that hypertension, we see, we're a little concerned. Our front office will put a little AI on the corner there. And as I'm walking Mrs. Jones to her chair, we're talking a little bit, and we hear that, she's been a little frustrated lately because she just has these headaches in the morning that just won't go away, and she doesn't know what to do about it. And so she's got these headaches right here, and she doesn't know what to do about it. So we sit Mrs. Jones down, and as a hygienist, I would say something like this. Hey, Hey, Mrs. Jones, could you open up real quick? I just want to do a real quick exam just to check things out before we really start. I still want to talk to you for a second, catch up. So hygienist, you look in the mouth real quick, and we noticed we've got some bruxism. We've got some yellowing on the tongue. And we also notice that we've got some tongue scalloping. So pause real quick. I've now got morning headaches, hypertension, and 3 intraoral signs. I've got 5 things wrong with Mrs. Jones, so to speak, that I could go to her with. Does this sound like a pretty similar case? Go and raise your hand for me if that sounds like something you would see in just a normal day, someone who's got quite a few of those things. Yeah, I got a few of you. So we're going to start to see this more commonly, and this is what I'm going to recommend that we do from a protocol standpoint. So this is your 3 favorite things protocol is what we call it. And what I'm going to do as a hygienist is I'm going to pick the 3 things that are the most interesting to me. And I use hygienist loosely. If you're a dental assistant, this also applies to you, okay? So I'm going to use this, and I'm going to pick my 3 favorite things, and I'm going to bring it up to Mrs. Jones very, very lightly. So this is what I would do as a hygienist, okay? Hey, Mrs. Jones, I was just doing some looking in your mouth real quick and looking over your medical history, and I'm a little concerned. With the morning headaches you've been having, the hypertension I see in your medical history, and the fact that you've got some teeth grinding going on, these things could be indicative of an airway issue, and I think you should do a test. Pause real quick. Doctor's team, who thinks that you or your team could easily bring up that question and ask it just like that? You find 3 things, you ask, go and give me your hand up, or say I can in the chat, let me know. Yes, a lot of teams, thank you very much. I don't think that's too hard, okay? Now, let's see what happens after this. Mrs. Jones looks at you and says, no. What happens when someone says no in the dental practice? Nothing happens. Now, if you're part of a particularly sensitive practice, I recommend installing a cry corner, okay? So when the patient says no, you can go over there and then come back, and I'm just kidding. You guys are dental professionals. You guys have one of the toughest jobs in the world, and you have the worst patients ever. Thank you. And I know you guys can handle no's all day long because you do it every day. So you guys rock, and that's not gonna be a problem. If Mrs. Jones says no, no problem. We move on with our dental appointment. Nothing changes. We're going to do the cleaning, or we're going to do the crown, whatever it is that we're there to do that day, we're just going to do it. hygiene. If the patient says yes, then we're going to say awesome. And at the end of the appointment, we'll let doctor know that. Okay. But in this example, Mrs. Jones says no. So we go through, we clean her teeth. And at the end of the appointment, the doctor is going to come into the room. And this is typically what happens. The doctor comes in, he says, so Chad, sorry, gotta go to this side of the screen. So Chad, is there anything else that we need to talk about with Mrs. Jones? Did you see anything concerning? And as a hygienist, I've been in her mouth for the last 45 minutes or so. So I'm like, well, Mrs. Jones has some pain on number 7. Looks like she's got a cavity on number 15, and number 42 doesn't exist. And as a doctor, I'm like, well, cool. Well, number 7's ugly, and we can probably fix number 15 with a filling. So we'll rip out 7 and fix 15 and call it a day. Let's go. And so we do our normal protocol there. And doctors, this is where you come in. Very, very, very important. If you're a doctor, raise your hand for me so I can see that. Doctors, what I need you to do here is, and this sounds silly, I know, but trust me, it works. After the dental conversation is done, after you've presented your clinical treatment plan to the patient as relates to the dental topic, we need to put a break in the conversation. And what we're going to do is very, very simple. Doctors, we're going to look at the hygienist in front of the patient, and we're going to say something like this. Hey, Chad, is there anything else we need to talk about? Real quick, doctors, I'm not even going to ask you to raise your hand because I know you can do that. We're just going to ask to change the topic with the patient. That's it. Okay. When the doctor asks that hygiene, this is what's going to do, what you're going to do. And dental assistants, if you're doing this in the recare chair, doctor's going to ask the question, and I'm going to try and do this in real time as much as possible. So I want you to pay attention. And the little details are very, very important. So we'll go through those in just a second here. I'm going to clap and be real time the entire time. Okay. So Chad, is there anything else we need to talk about? Dr. Smith, I was talking to Mrs. Jones earlier, and I'm a little concerned about her airway. With her medical history updated and the hypertension, that coupled with some morning headaches she's been having and the grinding I see in her mouth, I'm concerned that she has an airway problem, and I was hoping you could talk to her about that. Pause real quick. What was the first thing I did when doctor asked me if there was anything else? Nothing. I did nothing. Actually, I did something. I did what's called a pregnant pause. I took a breath for 3 seconds, and then I responded. Dr. Smith, I'm concerned, and I used the same 3 things as earlier. At this point, doctors, I'm going to show you what to do in just a second here. We're going to keep it brief. Doctors like to share, and in this instance, hygiene will kill me if you go on a 5-minute pitch about the importance of sleep and sleep apnea and airway. No, you have 45 seconds. I'll show you how to do that, okay? So pregnant pause, I said the same exact 3 things. I did it in front of the patient, and I looked at the doctor the entire time. Why do I do the pregnant pause? It's very, very simple. Who has kids? Raise your hand. If you've ever worked with children, whether it be at church, your family, anything like that, and you've got a kid who's got in trouble, you have a couple choices. You can raise your voice, you can throw things at them. It just depends on where you are and what's, appropriate for all that jazz. I personally just like to scare them. And in order to scare them, all I have to do is take a breath. All I have to do is this. And then Jacob, who's usually in trouble, will usually say about 5 things he wasn't in trouble for. He was in trouble for 1. And now he's in trouble for 6 because he's terrified that something really bad is going to happen. Because when I'm upset, I take a pause. That is culturally something that we do all the time. If you're a parent, you know what I'm talking about. Sometimes, you throw things or yell at them or whatever. That happens, when they're not listening or whatever. I see you, Kaylee. That happens. But the pregnant pause, in my opinion, is one of the most effective ways to scare the living lights out of any child. So that same dynamic is present here with adults. We know culturally that that's a cue, that something serious is about to happen, that the temperature is going to drop just 1 or 2 degrees. And now the patient's like, whoa, what is this airway stuff? Okay. So doctors, what happens after that? We're going to come in, we're going to reiterate the same 3 things, and we're going to give them a call to action. Okay. Very important call to action. All right. So here we go. Real time. Mrs. Jones, patients who exhibit signs, like bruxism, such as the hypertension and the morning headaches, they have a serious concern for an airway issue. And there's really only two choices. You could do a home sleep test in the comfort of your home, or you could do a study in a hospital setting where you do it overnight. Do it overnight, they watch you, and then we get a diagnosis there just to evaluate what's going on with your airway. What should you prefer? Then you wait. Sorry, I forgot to clap. Then you wait. The reality is that those are the only two options to diagnose a patient with sleep apnea. That's it. That's all there is. So we need to give the patient those options, and then we need to zip the lip, okay? Sorry, I don't mean to be disrespectful to doctors, but you don't have time to go through a 2-hour course on why the airway is important, okay? The reality is if they're choking in their sleep, they're gonna die faster, be more likely to be overweight, have more health issues. That's a reality. The only two options are those two tests. So quick 2-minute recap, and then we're gonna finish up with the rest of our slides here. So patient comes in, we dialogue, we find 3 things. Hygienist, hey, Mrs. Jones, I'm a little concerned because of your hypertension. I'm concerned because of your inability to go all the way back in the chair. I know it's scary because you choke a little bit. There's just some stuff going on with your airway, and I'm really concerned. I think you should do a test. No, I hate you. Okay, cool. We move on to the rest of our appointment. Come back to the doctor. We do our normal dental exam. Hey, Chad, is there anything else we need to talk about? Dr. Smith, I was talking to Mrs. Jones earlier, and I'm just concerned, partially because of her anxiety about going back and kind of choking while being back with any dental work that we're doing and that hypertension. I'm just concerned about her airway, and I was hoping you could talk to her about that. Well, Mrs. Jones, patients who they have a small airway, they actually have a pretty big problem. And there's really only 2 ways to evaluate if this is impacting their health and also the dentition. So what we need to do is we either need to get you to a home sleep test, or we need to get you to an in-lab test. What should you prefer? All right, say bye to Chad's 3 personalities because 2 of them are leaving, okay? So I'm here for that. And the reality is if we can keep that short, my life will be longer because hygienists won't fly to California to kill me, okay? Doctors, please, my life is important to me. We just got life insurance and my wife does not want to collect yet, okay? So here, when we're talking about this, we keep it brief and we give them that option. The last thing to consider is when we are giving them this option, we need to understand what our protocol is. If you are in a dental office that has their own equipment, then that checkup process is easy. Hey, Mrs. Jones, you can do a home sleep test. We have one at the front. You could take it home tonight. Or I can refer you to a medical center where they're going to watch you overnight to do a attended test. Which would you prefer? Real quick, show of hands, and lower all these hands right here. Who would rather do a test in the comfort of their own home, pay less money, be more comfortable? Yeah, almost every single person, 99 out of 100 people will say yes to the home sleep test, okay? And we'll talk about this on our next webinar, but Michael Cohen will go over the cost difference between a home sleep test and a polysomnogram. And using our recommendations, if you charge $140 to $200 for that test, you're saving the patient a boatload of money. You're saving them comfort and their ability to just go forward and really live a comfortable life with treatment that makes a difference. Now, Kimberly made an interesting comment, and it depends on insurance. And I will just say that we're going to recommend that we actually don't use medical insurance in a dental practice if you're just getting started. As a longer conversation, if you want to talk about medical insurance, I will tell you that medical insurance is the #1 killer of sleep programs in the US, and that it should be considered as a part of your developments, not a part of getting started, okay? Well, there's a lot to say on that matter. Mike will talk about that next month, so make sure you register. That link will be in your email afterwards here today. So that is our screening protocol, our 3 favorite things. And if we can bill those patients there, and we keep it simple, those patients are going to be more likely to do a test. So we do have some time for questions and answers. I do want to share, I know this is a webinar. I know that, I'm trying to get your chats and your questions and your hand raises and all that kind of stuff, limited feedback. But if you liked what you saw today and you want to have your team come to really learn how to do this your practice with custom answers and questions, and hear a doctor share with you his experience with this, and have Mike's perspective, not just questions that he's helping moderate, then you should really consider coming to the course. The course is taught by Michael Cohen, myself, and a clinical speaker. Usually it's Dr. Greg Manning. And this course, our next one, is the 20th and 21st of this month. We're discounting this by $200. And I just want to say, over the last year since we've been doing these courses, doctors leave these courses telling us that they have had more fun on our virtual course because they had their camera and microphone on than they did in some of their actual live courses pre-COVID. We bring one doctor and 14 for 2 days. Each person gets 14 CEs, and all you have to pay is $400. So I don't know of another CE deal quite like that, but I can tell you that if you want to implement sleep and do 3 to 5 appliances a month, this is how you do that. This type of protocol. So with that,
I got to pause you there, man. I just have to say, if you all are looking for a sleep course, to Chad's point, there's valuable content. We focus on workflow, all the cool stuff. You're going to have a blast because it's more of this, but better because you can actually talk. We're not just talking at you. Right. That being said, I don't think I've ever seen a presenter have 3 personalities on camera on purpose. So, just consider yourself warned. If you want to show up Friday and Saturday and hang out and get more of that, that's what it's all about. So
you should also know the bad jokes continue. Yeah, I've been married for a year. I forgot. That was the disclaimer. Yeah, we forgot that one. Yeah, my wife's been working on it for a year, guys. I'm broken. So the bad jokes, they're just going to keep coming. If you like them, you should come.
Cool. Hey, so I'm gonna keep us on track here because we actually do have a handful of questions. And just so everybody knows, the CE link is in the chat. You can click that, get your CEs. If you want answers to questions or you have your own, stick around. We're going to go through that now. Just one last plug on the slide that he has up there. Get your tickets while you can. I don't know how many. Did you say how many are left?
We just had a webinar last 2 nights ago, and we sold a bunch of them. So we're down to 7 tickets left for this event coming up.
So yeah, if it works for you, great. If not, shoot us a message. Let us know, and we can make sure you're taking care of some at a different date.
Awesome.
Cool. Let me hit you with the questions, sir. April, has our home sleep test just as accurate as in-lab tests?
Yeah. So home sleep studies are required by the FDA to be 90% lead to lead accurate to an in-lab study. Part of their actual device as well as their software are both FDA approved. Most home sleep studies operate in the 94 to 97% lead to lead accuracy. So yes, very, very accurate.
Cool. I'll translate English. Yes, they're equally as accurate. And the only thing you're missing is the number of channels. And when you do what Chad's, this is part of the webinar next month that I'll be teaching, but your scope of practice in a dental office directly aligns with the scope of a home sleep test, which is looking for airway issues.
Yeah, I do want to say one thing real quick. If you have to go, the CE link is in the chat. It'll also be emailed to you later. But if you want to stick around for these questions, we've got some really good questions here. So I see a few here, so stick around for those questions. Go ahead, Mike.
All right, so Heather asks, what are the costs? What is the cost for the home sleep test for the patient?
So that depends on your office and your workflow. If you're going to use an in-house model, which we typically recommend because it streamlines your process, you're going to be probably charging between $140 and $200 on a fee-for-service basis. Now, if you're using a shipping company, like if you were to have Awaken Sleep ship your patient a test to get them diagnosed, we charge $347. Now, we've got to ship equipment to Georgia. Okay. So there's a lot more cost for us in that. The other thing is your timeline. You're going to have 2 to 3 weeks to ship a test and get the results versus 7 days to treatment plan your patient who you test with your own unit.
Yep. Increased sense of urgency and higher conversion, higher patient acceptance. Yeah. Okay. Shifting gears a little bit. You mentioned something that was really important. I don't want people to miss this. In your 3 personalities protocol, you were talking about talking to patients and the idea of laying them back. So the further you lay them back, the more uncomfortable they are. The patients that are responding like, oh no, that's too far. No, I'm not good. They have a hard time breathing. Can you dive into that just a little bit more and talk about how that would actually relate to practices that have long-term patients and they're just starting the airway conversation? Because I know that's a unique tie-in.
Yeah. So let's think about this real quick. If sleep apnea is when we have the cessation of breathing because the airway is collapsed, and the patient doesn't want to lean back because their airway is at risk of collapsing while they're awake in your dental chair, that means their best possible airway isn't good enough. Their best possible airway puts them at risk for that airway collapse. And so if they are having anxiety because their oxygen levels are decreasing or because of the airflow being reduced, then that is a great pain point to say, I'm concerned and this isn't okay. We need to do these things. So that's why. And it just directly relates to the airway, and it's a huge, loud pain point.
Got it. So Shanda, thank you for the shout out. She said it's great info and she's motivated to start implementing in their office.
Yeah.
So, good job.
Jessica asked a question about the actual survey. She said, what is PACE AJD number? If you don't know what it is, then it doesn't apply to you. That's for doctors who are registered with the AJD. So don't worry about that. Leave it blank.
Yep. So Fatima said she works in a pediatric office. Could a sleep study ever be needed with kids or teens or is it more in relation to a general office?
Great question. So I mentioned the Knox T3 unit earlier. It's one of the only units in the US that's approved to diagnose children. If you're doing your own treatment protocol, I recommend getting one because I have several friends that are ortho in the pediatric world that get these kids who come in, they have obvious airway issues, and to get them to do a sleep test through the ENT is just a hassle. So they offer a discounted home sleep test, very simple, very fast, and now you have a diagnosed problem and the level of severity. So yes, home sleep testing definitely plays a role. Your conversation is going to be different, but typically the outcome of the test is the same. And then from there, you have a multidisciplinary approach for treatment.
Yeah, cool. So we have, thank you. We have two questions on Mallampati. So
okay.
Really, one is, can you go over the Mallampati classification again? And number two, is it different or does it differ when you're sitting up or lying down?
Yeah. So where is, yes, there it is. Okay. And Summer actually asked a question. Can you link or spell the recommended home sleep test? That depends on your practice. Yeah. Okay, cool. Mallampati. So real quick on the Mallampati, we're going to have the patient sit up, and I'll come back to that question in just a moment here. We're going to have the patient sit up. We're going to be looking at the airway while they're sitting up, have them stick their tongue all the way out, and we're going to make sure they do not say ah. Ah raises the tissue in the back of the throat. That gives us a clear view of infection, which we're not looking for. We're looking for airway, okay? So have their stick their tongue out, snap a picture. We're gonna look for the distance between the tongue and the soft and hard palate. If they are class 1 or 2, they're not at risk. If they're class 3 or 4, they're considered to have moderate risk of an airway collapse. Why we don't have the patient lean back? What we're looking for is that distance between the tongue and the soft and hard palate. And what we want to see is how the tissues hang naturally. Otherwise, if we're putting them in a backward position, that could cause the tongue to look different, as well as the soft tissue in the back of the throat to look different. And we want to get the best picture of their best possible airway, and that's going to be with them sitting up. If they're leaning back, you're going to have a lot more 3s and 4s, which is fine, but it's not really the way the test is designed. So we want to give them their best possible airway and see from there.
Yeah. And I would only add to that that's why you tell them not to say ah. It's the same thing. You're trying to keep the uvula where it belongs with gravity and see where it's collapsing.
That's right.
Yep. Acid reflux. Can it also stain the teeth?
So I've heard of acid reflux staining teeth, but I don't think it's accurate. What I've seen is that acid actually contributes to the additional wear and tear of teeth. That being because the high acid content actually wears down the dentition, which high acid level in the body, the blood, and the gums is directly associated with sleep apnea. When we don't get proper restorative sleep, it changes the pH of our body.
Yep. and hygiene, you all know it increases periodontal disease.
Yep.
So yeah, it's no bueno.
Yeah.
All right. Last question, official question for the night. Can you do oh no, somebody threw one in there. I'll ask that in a second. Can you do a double backflip blindfolded on a trampoline?
I can't do a single backflip blindfolded. I can't do a single backflip, just like period on a trampoline. I don't know trampolines and I are not friends. No.
All right. So screening wise, so on a class 2, a retrognathic patient, it's okay. Is it okay if it disappears below the tongue, provided there is space between the tongue and the soft palate?
We're talking about the uvula?
Yeah.
Okay, sorry. I was like, what is it? So if the uvula is long, it's long. So I would say that patient should still be talked to about an airway issue. And I would rather rule out an airway issue. We're always ruling out things, right? Speaking in the affirmative. The reality is that no one is born with a long uvula, no matter what class they are. So that class 2 might contribute to their airway issue, but that's still an airway issue. So I would still get them tested.
Yep. Yeah. And I would only add that Dr. Malampati, when he made the classification, there's no distinction in dental classification.
Right.
It's just the depth of the soft palate and the height of the tongue. And that's what you're looking for.
Right. Yeah. And like I said, it's funny it's used so much in dental, especially for anesthesiology, because it is actually just something they use in general surgery in the medical community. So just has a ton of application elsewhere.
Cool. So Summer had the home sleep test question. I put it in the chat, but I'll tell it live to everybody. For pediatric patients, there's only a couple of home sleep tests on the market that do those tests. Chad mentioned the Knox T3. I put the spelling there for pediatric patients. For adults, we do recommend the Philips Alice Night 1. It's a really versatile unit, and it's much more appropriate and cost-effective to run for adults. If you want a complimentary coaching call, Awaken to Sleep does those. We actually retail both of those units and a few others. The reality is we just want to get you the answers that you're looking for your practice. So,
well, and I'll say this, the dealers who sponsor this course also retail the Alice Night 1 units. So we can help you get back to those guys for sure. So just let us know.
Yep. Cool.
All right. Did we miss any questions? If not, I believe that's the end. Like Mike said, we're going to have that email to you guys in your link. And if you enjoyed today, if you laughed at all, please let us know. We're going to be doing this course in August 2021, and we'd like you to bring your team and really start doing this thing in your practice, because it could just be 1-2 day course away from some good success. So with that, we're going to wrap up today. We'll hang around for any last minute questions, but other than that, you guys are free to go. Thank you so much.
I still can't believe you pull off your 3 personalities, man. Every time.
Well, one is static. Okay. This one is static. The other 2, I don't know. That doctor's got some weird stuff going on, but I'm just kidding.
Sheena's building a cry corner in their office tomorrow.
Yes.
Go Sheena.
I'm telling you, get some pillows, get like some padded. Oh wait, padded walls might be a little far, but you guys know that would be great. Yeah.
Pillows, paraffin wax, and a cry corner.
That's right.
It's where it's at. Yeah.
All right, guys. We're going to turn off the webinar. Check your email for those links at the end here, guys. Have a great night, and we'll talk to you soon.
Have a good one.